Atrial fibrillation, stroke, and novel anticoagulation. Pamela Rama MD FACC. Baptist Heart-Wise. Outcome: stroke. 130,000 Americans die from stroke each year, 1 of every 19 deaths. In the US, someone has a stroke every 40 seconds. Every year about 795,000 people in the US have a stroke, and is a major cause of disability. Stroke cost the nation $38.6 billion annually, healthcare cost, medications, lost productivity. Risk factors for stroke. You cannot change. Family history: male, less than 55 years/O, female, less than 65 years/O. Age. Race. Risk factors for stroke: cigarette smoking, sedentary lifestyle, obesity, dyslipidemia, diabetes mellitus. Atrial fibrillation. Symptoms: sudden numbness or weakness of the face, arm or legs. Sudden confusion or trouble speaking or understanding others. Sudden trouble seeing in one of both eyes. Sudden trouble walking, dizziness, loss of balance or coordination. Sudden severe headache with no known cause. Atherosclerosis. What is atherosclerosis? Over time, fatty deposits called plaque build up within the artery, causing the artery to become narrow. This is atherosclerosis. If the plaque affects the coronary arteries, this is called coronary artery disease. Stroke etiologies: the challenge of cryptogenic stroke. Types of ischemic stroke. Atherothrombotic, 25 to 30%. Stenotic artery feeding area of infarction. Cardioembolic, 20%. A thrombus or other material dislodges from the heart or aortic arch. Other/uncommon, 5 to 10%. Cryptogenic, 25 to 40%. Unknown cause. Artery occlusion, 85%. Vessel rupture, 15%. Adams H.P. Jr., Classification of Subtype of Acute Ischemic Stroke. Stroke. January 1993, 24, 35 to 41. Atrial fibrillation: 15 to 20% of ischemic strokes due to AFib. 3 million people are diagnosed with AFib. Projected to increases to 12 million patients in 30 years. 70% of AFib patients 65 to 85 years old. In 2005 cost $6.5 billion in hospital costs. 15 to 20% of ischemic strokes due to AFib. 80,000 people die a year from AFib and its complications. Copyright the American College of Cardiology. From 2014 AHA/ACC/DRS Guideline for the Management of Patients with Atrial Fibrillation, Executive Summary, a report of the American College of Cardiology/American Heart Association Task Force on Practice Guidelines and the Heart Rhythm Society. J. Amcol Cardiol. 2014 /6421, 2246 to 2280. DOI 10.1016/J.Jack.2014.03.021. Table title: Selected Risk Factors and Biomarkers for AF. Date of download: 3 August 2015. Copyright the American College of Cardiology. All rights reserved. Definition of AF. Term definition: paroxysmal AF, persistent AF, permanent AF, non-valvular AF, AF that terminates spontaneously or with intervention within 7 days of onset, continuous AF greater than 7 days. Patient and clinician make a joint decision to stop further attempts to restore and/or maintain sinus rhythm. AF in the absence of mitral stenosis, mechanical or bioprosthetic heart valve or mitral valve repair, sinus rhythm. Atrial fibrillation. Atrial flutter. AF prevalence stratified by age and sex. 1. The lifetime risk of developing AF after age 40 is 1 in 42. Go A. et al. Prevalence of diagnosed atrial fibrillation in adults. National implications for rhythm management and stroke prevention. The anticoagulation factors in atrial fibrillation. Arterial study. JAMA. 2001, 285, 2370–2375. Lloyd-Jones D. et al. Lifetime risk for development of atrial fibrillation. The Framingham Heart Study. Circulation. 2004 110, 1042–1046. Selects symptoms from 147 patients during AF1. AF symptoms. Selects symptoms from 147 patients during AF1. Palpitations. Fatigue. Shortness of breath. Exercise. Intolerance. Dizziness. Angina. Syncope. Luderitz B. et al. Quality of life in atrial fibrillation. Journal of Interventional Cardiac Electrophysiology. 2000, 4–201–209. AF discovery, monitoring. Symptoms are not a reliable indicator of AF. 90% of AF episodes are asymptomatic. 1. 20% of reported symptoms are due to AF1. External monitors, Holter monitors or event recorders. Low yield due to poor compliance. Intermittent sampling. 2. Implantable systems, for example pacemaker ICD. Sensitivity of 100% and ppv of 95%. 3. Can only be used in indicated patients. 1. Strickberger et al. Heart rhythm. 2005 2–125–31. 2. Ziegler et al. Heart rhythm. 2006 3, 1445–1452. 3. Pura-Fellner et al. Pacing Clan Electrophysiol. 2004 27–983–92. Trend study subgroup analysis. 1. Newly detected AF, DAF, in patients with thromboembolic events. Of 163 patients with previous ischemic stroke/TIA, no known AF, and continuous monitoring via pacemaker or ICD, DAF greater than 5-minute duration was found in 45 patients, 28%. The majority of DAF patients, 73%, had AF on less than 10% of follow-up days, making it highly unlikely to be detected by standard monitoring techniques. Time from device implant, months. 3 mo. 6 mo. 9 mo. 12 mo. Freedom from AF. 0.5. 0.6. 0.7. 0.8. 0.9. 1.0. Number at risk. 163. 127. 111. 106. 67. 89% of NDAF patients identify beyond 1 day. 78% of NDAF patients identify beyond 7 days. 60% of NDAF patients identify beyond 30 days. This is the trend study subgroup analysis. This graph shows this group within this study, 163 patients, and how long it took to identify newly diagnosed atrial fibrillation, NDAF. The graph shows that 89% of the patients weren't identified until out beyond 1 day, 24 hours Holter would not work, 78% were not identified until out beyond 7 days, 7-day monitor would not work, and 60% with NDAF were not identified until beyond 30 days, 30-day monitors would not effectively find this AF. Methods and results. Trends was a prospective, observational study enrolling patients with greater than equals 1 stroke risk factor, heart failure, hypertension, age greater than equals 65 years, diabetes, or prior to A, receiving pacemakers or defibrillators start. Monitor atrial tachycardia, AT/AF burden, defined as the longest total AT/AF duration on any given day during the prior 30-day period. This time-varying exposure was updated daily during follow-up and related to TAE risk. Annualized TAE rates were determined according to AT/AF burden subsets: 0 low, less than 5.5 hours, median duration of subsets with non-zero burden, and high, greater than equals 5.5 hours. A multivariate Cox model provided hazard ratios including terms for stroke risk factors and time-varying AT/AF burden and antithrombotic therapy. Patients, N equals 2,486, had at least 30 days of device data for analysis. During a mean follow-up of 1.4 years, annualized TAE risk, including TIAs, was 1.1% for SIR, 1.1% for low, and 2.4% for high burden subsets of 30-day windows. Compared with zero burden, adjusted hazard ratios, 95% Cs, in the low and high burden subsets were 98, 0.34 to 2.82, p equals 0.97, and 2.20, 0.96 to 5.05, p equals 0.06, respectively. Conclusions: the TAE rate was low compared with patients with traditional AF with similar risk profiles. The data suggest that TAE risk is a quantitative function of AT/AF burden. AT/AF burden greater than equals 5.5 hours on any of the 30 prior days appeared to double TAE risk. Additional studies are needed to more precisely investigate the relationship between stroke risk and AT/AF burden. Circarrhythmia Electrophysiology. 2009 2:00-00. Ziegler P. et al. Incidence of newly detected atrial arrhythmias via implantable devices in patients with a history of thromboembolic event stroke. 2010 41:00-00. Glotzer, Trend Study 1 Topic, Relationship between atrial arrhythmia burden and stroke risk. Prospective, observational study analyzing 2,486 patients with greater than 1 stroke risk receiving pacemakers or defibrillators that monitor AT/AF burden. AT/AF burden greater than 5.5 hours on any of 30 prior days appeared to double thromboembolic TAE risk. This slide shows the thromboembolic risk for a patient in the Trend study with a high AT/AF burden greater than equals 5.5 hours. If the patient in the study had AF greater than equals 5.5 hours on any day in the preceding 30 days, they had almost 2.4x, a 2.5 increased thromboembolic TAE risk. Glotzer et al. The relationship between daily atrial tachyarrhythmia burden from implantable device diagnostics and stroke risk. The Trend study Circarrhythmia Electrophysiology. 2009. AF prevalence of AF in stroke cases by age 1. 30.7%, 18.8%, 6.5%, 8.5%, 50 to 59, 60 to 69, 70 to 79, 80 to 89. Wolf B. et al. Atrial fibrillation as an independent risk factor for stroke. The Framingham Study. Stroke 1991, 22 to 983 to 988. Cryptogenic stroke. Why AF matters. AF equals 5-fold increase for stroke risk. Superscript 1. Up to 90% of paroxysmal atrial fibrillation (PAF) episodes may be asymptomatic. Squared. Risk of stroke annually is equal for PAF and permanent AF cubed. Detection of AF in cryptogenic stroke patients changes treatment. Guidelines state change from antiplatelet to OAC4. Wolf P.A. et al. Stroke 1991 22 to 983 to 988. Israel et al. JAM Cardiol. 2004 43 47 to 52. Page, R.L. et al. Circulation. 1994 89 to 224 to 227. Hart R.G. et al. Cardiol. 2000. 35 to 183 to 187. Cam et al., European Heart Journal. 2012, 33, 2719 to 2747. Adjusted stroke rate %/year. CHADS score. CHADS 2 score. Patients. N equals 1733. Adjusted stroke rate %/year. 120. 1.9. 1. 463. 2.8. 2. 523. 4.0. 3. 337. 5.9. 4. 220. 8.5. 5. 65. 12.5. 6. 18.2. CHADS 2 risk. Score. CHF. 1. Hypertension. Age greater than 75. Diabetes. Stroke or TIA. 2. CHA2DS2 VASC score. CHA2DS2 VASC risk score. CHF all of less than 40%. 1. Hypertension. Age greater than 75. 2. Diabetes. Stroke/TIA/thromboembolism. Vascular disease. Age 65 to 74. Female. CHA2DS2 VASC. Score. Patients, N equals 7329. Adjusted stroke rate, %/year. 1. 422. 1.3. 2. 1230. 2.2. 3. 1730. 3.2. 4. 1718. 4.0. 5. 1159. 6.7. 6. 679. 9.8. 7. 294. 9.6. 8. 82. 9. 14. 15.2. Anticoagulants for AFib. Copyright the American College of Cardiology. From 2014 AHA/ACC/DRS Guideline for the Management of Patients with Atrial Fibrillation, a report of the American College of Cardiology/American Heart Association Task Force on Practice Guidelines and the Heart Rhythm Society. J. Amcol Cardiol. 2014 /6421, E1E76. DOI 10.1016/J.Jack.2014.03.022. Figure legend. Active W indicates atrial fibrillation clopidogrel trial with irbesartan for prevention of vascular events. W, AF, atrial fibrillation, AFISAC, atrial fibrillation, aspirin and anticoagulant therapy study, ATIFs, antithrombotic therapy in atrial fibrillation study, BAR-ATIF, Boston Area Anticoagulation Trial for Atrial Fibrillation, CAFA, Canadian Atrial Fibrillation Anticoagulation, C, Confidence Interval, AFT, European Atrial Fibrillation Trial, ESPS, European Stroke Prevention Study, JAST, Japan AF Stroke Prevention Trial, LAZAF, Low-Dose Aspirin, Stroke, Atrial Fibrillation, NASPEF, National Study for Prevention of Embolism in Atrial Fibrillation, PATIF, Primary Prevention of Arterial Thromboembolism in Non-Rheumatic Atrial Fibrillation, SAFT, Swedish Atrial Fibrillation Trial, SIFA, Studio Italiano Fibrillazione Atriale, SPAF, Stroke Prevention in Atrial Fibrillation Study, SPINAF, Stroke Prevention in Atrial Fibrillation, and UKTR, United Kingdom - transient ischemic attack. Date of download: 3 July 2015. Copyright there, American College of Cardiology. All rights reserved. Warfarin old standby for stroke prevention in AFib. Reduces stroke in AFib by 64%. Higher rates of intracranial and other hemorrhage. Issues with compliance, diet limits, drug interaction, new kids on the block. All are indicated for stroke prevent in AF that is non-valvular. All three drugs do not require INR monitoring. All three drugs have no diet or restrictions. All three drugs have renal dosing for SVL less than 30. Dabigatran Pradaxa. Dabigatran Pradaxa. Prodrug converted via serum esterase to active drug. Direct thrombin inhibitor. 80% renal elimination. Half-life is 12 to 17 hours. Fully anticoagulated in most patients within 90 minutes. PTT can be 1.5 to 2.0x of lab control. Thrombin time can be used. Rely, Dabigatran. Rely, a non-inferiority trial. Atrial fibrillation. Greater than or equal to 1 risk factor. Absence of contraindications, 3+ valve regurgitation. 951 centers in 44 countries. 2 years of follow-up. 64% of patients in the warfarin arm had INRs 2 to 3. Blinded event adjudication. R. Open. Blinded. Warfarin. Adjusted. 2 Indian rupees to 3.0. N equals 6,000. Dabigatran etexylate. 110 mg bid. N equals 6,000. Dabigatran etexylate. 150 mg bid. N equals 6,000. Baseline characteristics. Dabigatran 110 mg. Dabigatran 150 mg. Warfarin. Randomized. 6,015. 6,076. 6,022. Mean age, years. 71.4. 71.5. 71.6. Male, percent. 64.3. 63.2. 63.3. CHADS 2 score. Mean. 0 to 1%. 2%. 3+%. 2.1. 32.6. 34.7. 32.7. 2.2. 32.2. 35.2. 30.9. 37.0. 32.1. Prior stroke/TIA, percent. 19.9. 20.3. 19.8. Prior ME, percent. 16.8. 16.9. 16.1. CHF, percent. 31.8. 31.9. Baseline ASA, percent. 40.0. 38.7. 40.6. Warfarin naive, percent. 49.9. 49.8. 51.4. Rely stroke or systemic embolism. 0.50. 0.75. 1.00. 1.25. 1.50. Dabigatran 110 versus warfarin. Dabigatran 150 versus warfarin. Non-inferiority. P-value. Less than 0.001. Superiority. 0.34. HR, 95% C. Dabigatran better. Warfarin better. Rely, hemorrhagic stroke. 0.04. 0.03. D 110 mg versus warfarin. D 150 mg versus warfarin. RR equals 0.31. 95% C equals 0.17 to 0.56. P less than 0.001. RR equals 0.26. 95% C equals 0.14 to 0.49. Cumulative hazard rates 0.02. Warfarin 0.01. Dabigatran 110. Dabigatran 150. 0.0. 0.5. 1.0. 1.5. 2.0. 2.5. Years of follow-up. Rely, dabigatran conclusions. The 150 mg dose significantly reduced stroke compared to warfarin with similar bleeding risks. The 110 mg dose, not in US, had equal stroke rates as warfarin with less major bleeding. Both doses markedly reduced intracerebral, life-threatening, and total bleeding. Dyspepsia major side effect. Dabigatran approved by the FDA October 19, 2010. Only approved the 150 mg and 75 mg dose based on superiority to warfarin, despite bleeding risk. For renal patients with GFR less than 30, reduce the dose to 75 mg BID. If drug is in a bottle, only good for 4 months due to exposure to humidity. Blister packs are okay. 30 days of 150 mg dose BID is $245. Rivaroxaban, Xelto. Rivaroxaban direct factor SAR inhibitor good gut absorption. TF/VA. Direct factor SAR inhibitor. Good gut absorption. Full anticoagulation in about 4 hours, half-life 5 to 13 hours. 1/3 renal excretion, 2/4 CPY 450 liver enzyme. Lasts over 24 hours, so once a day dosing is okay. X 9. IXA. VIA. Rivaroxaban. VAR. SAR. 2. IA. Fibrinogen. Fibrin. Rocket AF, Rivaroxaban. Study design atrial fibrillation. GO2 536W_script.ppt. The 13th of April 2017, 6:31 and 8 seconds p.m. Study design. Risk factors. CHF. Hypertension. Age 75. Diabetes. Or stroke, TIA or systemic embolus. At least 2 or 3 required. Atrial fibrillation. Rivaroxaban. Warfarin. Randomize. Double-blind, double-dummy. N 14,000. 20 mg daily. 15 mg for CL 30 to 49 ml per minute. INR target, 2.5. 2.0 to 3.0 inclusive. INR goal was 57.8% of warfarin patients. Monthly monitoring. Adherence to standard of care guidelines. Primary endpoint, stroke or non-SNES systemic embolism. Baseline demographics. Rivaroxaban, N equals 7081. Warfarin, N equals 7090. CHADS 2 score, mean 2%, 3%, 4%, 5%, 6%, 3.48, 13, 43, 29, 2, 3.46, 44, 28, 12. Prior VKAUs, percent. 62. 63. Congestive heart failure, percent. Hypertension, percent. 90. 91. Diabetes mellitus, %. 40. 39. Prior stroke/TIA/embolism, %. 55. Prior myocardial infarction, %. 17. 18. Based on intention to treat population. Rocket AF, primary efficacy outcome stroke and non-SNES embolism. Rivaroxaban. Warfarin. Event rate 1.71. 2.16. Warfarin. Rivaroxaban. Cumulative event rate, %. HR, 95% C, 0.79, 0.66, 0.96. P-value non-inferiority, less than 0.001. Days from randomization. No. At risk. Rivaroxaban 6958, 6211, 5786, 5468, 4406, 3407, 2472, 1496, 634. Warfarin 7004, 6327, 5911, 5542, 4461, 3478, 2539, 1538, 655. Event rates upper 100 patient years. Based on protocol compliant on treatment population. Rocket AF, primary safety outcomes. Rivaroxaban. Warfarin. Event rate or N, rate. HR, 95% C. P-value. Major. Greater than 2 grams/dl/Hgb drop. Transfusion, greater than 2 units. Critical organ bleeding. Bleeding causing death. 3.60. 2.77. 1.65. 0.82. 0.24. 3.45. 2.26. 1.32. 1.18. 0.48. 1.04. 0.90. 1.20. 1.22. 1.03. 1.44. 1.25. 1.01. 1.55. 0.69. 0.53. 0.91. 0.50. 0.31. 0.79. 0.576. 0.019. 0.044. 0.007. 0.003. Intracranial hemorrhage. 55. 0.49. 84. 0.74. 0.67. 0.47. 0.94. Intraparenchymal. 37. 0.33. 56. 0.49. 0.67. 0.44. 1.02. 0.060. Intraventricular. 2. 0.02. 4. 0.04. Subdural. 14. 0.13. 27. 0.27. 0.53. 0.28. 1.00. 0.051. Subarachnoid. 1. 0.01. Event rates upper 100 patient years. Based on safety on treatment population. Rocket AF conclusions. Rivaroxaban non-inferior to warfarin. However, on an intent to treat basis, it is superior to warfarin. No different than warfarin in bleeding rates. Less intracranial and fatal bleeding with rivaroxaban. Rivaroxaban, Xelto. Drug approved for DVT prophylaxis in knee and hip patients by FDA on July 1, 2011. FDA approval on November 1, 2011 for stroke prevention in AF. Approved for treatment in active DVT and P. Rivaroxaban, Xelto dosed as 20 mg a day at night. Reduced to 15 mg a day for GFR less than 30. 30-day cost about $220. Apixaban, Eliquis. Apixaban direct factor SAR inhibitor absorbed in gut 50% bioavailable. Half-life 6 hours. Metabolized by liver CYP 450. 27% excretion in urine, rest in stool. 5 mg bid. 2.5 mg bid if have two of following: over 80, less than 60 kg, or creatinine greater than 1.5. Aristotle, Apixaban. Atrial fibrillation with at least one additional risk factor for stroke. Inclusion risk factors: age greater than or equal to 75 years, prior stroke, TIA, or SE, HF of less than or equal to 40%, diabetes mellitus, hypertension, randomize, double-blind, double-dummy, N equals 18,201. Major exclusion criteria: mechanical prosthetic valve, severe renal insufficiency, need for aspirin plus phenylpyridine. Apixaban 5 mg oral twice daily. 2.5 mg bid in selected patients. Warfarin. Targeting 2-3. Warfarin/warfarin placebo adjusted by INR/sham INR. Based on encrypted point-of-care testing device. Primary outcome: stroke or systemic embolism. Hierarchical testing: non-inferiority for primary outcome, superiority for primary outcome, major bleeding, death. Aristotle, trial metrics. Patients enrolled from December 2006 to April 2010. Median duration of follow-up 1.8 years. Drug discontinuation in 25.3% of apixaban and 27.5% of warfarin patients, p equals 0.001. Vital status at the end of the trial was missing in 380, 2.1%, patients. Withdrawal of consent in 199 patients. Loss to follow-up in 69 patients. Median and mean times in therapeutic INR range among warfarin-treated patients were 66.0 and 62.2%. Aristotle, objectives. Primary objective: to determine whether apixaban is non-inferior to warfarin at reducing stroke, ischemic or hemorrhagic, or systemic embolism in patients with atrial fibrillation and at least one additional risk factor for stroke. Primary safety outcome: major bleeding according to the International Society of Thrombosis and Hemostasis, ISTH, definition. 2 gram drop in hemoglobin. 2 units of transfusion. Bleeding in critical organ. Death. Aristotle, baseline characteristics. Apixaban. N equals 9,120. Warfarin. N equals 9,081. Age, years, median, 25th, 75th the percentile. 70, 63, 76. Women, percent. 35. Region, percent. North America. 25. Latin America. 19. Europe. 40. Asia/Pacific. 16. Warfarin naive, percent. 43. CHAD score, mean, plus/SD. 2.1, plus/1.1. 1%. 34. 2%. 36. Greater than or equal to 3%. 30. Aristotle, baseline characteristics. Apixaban. N equals 9,120. Warfarin. N equals 9,081. Qualifying risk factors, percent. Age greater than or equal to 75 years. 31. Prior stroke, TR, or SE. 19. 20. Heart failure or reduced LVF. 35. 36. Diabetes. 25. Hypertension. 87. 88. Renal function, cl/ml per minute, %. Normal, greater than 80. 41. Mild impairment, greater than 50 to 80. 42. Moderate impairment, greater than 30 to 50. 15. Severe impairment, less than or equal to 30. 1.5. Arterial, primary outcome stroke, ischemic or hemorrhagic, or systemic embolism. P. Non-inferiority less than 0.001. 21% RRR. Apixaban 212 patients, 1.27% per year. Warfarin 265 patients, 1.60% per year. HR 0.79, 95% C, 0.66 to 0.95, P. Superiority equals 0.011. No. At risk. Apixaban 9120, 8726, 8440, 6051, 3464, 1754. Warfarin 9081, 8620, 8301, 5972, 3405, 1768. Aristotle, efficacy outcomes. Apixaban. N equals 9120. Warfarin. N equals 9081. HR, 95% C. P-value. Event rate. %/year. Stroke or systemic embolism. 1.27. 1.60. 0.79, 0.66, 0.95, 0.011. Stroke. 1.19, 1.51, 0.79, 0.65, 0.95, 0.012. Ischemic or uncertain. 0.97, 1.05, 0.92, 0.74, 1.13, 0.42. Hemorrhagic. 0.24, 0.47, 0.51, 0.35, 0.75. Less than 0.001. Systemic embolism, SE. 0.09, 0.10, 0.87, 0.44, 1.75, 0.70. All-cause death. 3.52, 3.94, 0.89, 0.80, 0.998, 0.047. Stroke, SE, or all-cause death. 4.49, 5.04, 0.89, 0.81, 0.98, 0.019. Myocardial infarction. 0.53, 0.61, 0.88, 0.66, 1.17, 0.37. Aristotle major bleeding ISTH definition. 31% RRR. Apixaban 327 patients, 2.13% per year. Warfarin 462 patients, 3.09% per year. HR 0.69, 95% C, 0.60 to 0.80, P less than 0.001. No. At risk. Apixaban 9088, 8103, 7564, 5365, 3048, 1515. Warfarin 9052, 7910, 7335, 5196 2956 1491. Aristotle, bleeding outcomes. Apixaban. N equals 9088. Warfarin. N equals 9052. HR, 95% C. P-value. Event rate. %/year. Primary safety outcome, ISTH major bleeding. 2.13. 3.09. 0.69, 0.60, 0.80. Less than 0.001. Intracranial. 0.33. 0.80. 0.42, 0.30, 0.58. Gastrointestinal. 0.76. 0.86. 0.89, 0.70, 1.15. 0.37. Major or clinically relevant non-major bleeding. 4.07. 6.01. 0.68, 0.61, 0.75. Gustosevere bleeding. 0.52. 1.13. 0.46, 0.35, 0.60. TIMI major bleeding. 0.96. 1.69. 0.57, 0.46, 0.70. Any bleeding. 18.1. 25.8. 0.71, 0.68, 0.75. Compared with warfarin, apixaban, over 1.8 years, prevented 6 strokes, 15 major bleeds, 8 deaths, 4 hemorrhagic, 2 ischemic/uncertain type, per 1,000 patients treated. Aristotle, summary. Treatment with apixaban as compared to warfarin in patients with AF and at least one additional risk factor for stroke. Reduces stroke and systemic embolism by 21%, p equals 0.01. Reduces major bleeding by 31%, p less than 0.001. Reduces mortality by 11%, p equals 0.047. With consistent effects across all major subgroups and with fewer study drug discontinuations on apixaban than on warfarin, consistent with good tolerability. Aristotle, conclusion. In patients with atrial fibrillation, apixaban is superior to warfarin at preventing stroke or systemic embolism, causes less bleeding, and results in lower mortality. Apixaban approved by FDA December 31, 2012. Only U.S. indication is for non-valvular AFib. About $220 a month, $5 pill. Pharmacology summary. Anticoagulants for AFib. How to control bleeding. Time. All the new agents have short half-lives. Fresh frozen plasma, beat K factors, 2, 7, 9, 10. Recombinant factor via A, initiates thrombin generation via factor X activation. Prothrombin complex concentrates, PCC, virus reduced, concentrated, pooled plasma products with 3 or 4 VK dependent factors. Febulin and prophylline, low non-active factor 7 with predominate 2, 9, 10. Bariplex, factors 2, 7, 9, 10, stimulate thrombin. How to control bleeding. Activated PCC, APC, freeze-dried sterile human plasma fractions. Fiber NF, activated factor 7 with non-active 2, 9, 10. Factors are several options, Xelto/Eliquis. Can follow the PT. FFP not recommended. Recombinant factor via A, animal studies only, not recommended. PCCs. Study in 2011 showed 50 IU/kg PCC bolus would reverse SAR agent. Officially recommended agent. Pradaxa reversal follow-up. Hemodialysis can remove 60% of drug in 2 to 3 hours. Limited real-life data. FFP is not recommended. Recombinant factor VIA. Some data it can work, but no clinical data. PCC. Some animal data, no human data. So I need surgery/procedure. So I need surgery? Holding new agents. All three agents do carry the following black box warning: increased thrombotic event and stroke risk when discontinuing. Pick your agent. In patients with non-valvular AFib, if must DC, pick your agent. For reasons other than pathological bleeding, consider administering another anticoagulant. Use a Lovenox or heparin bridge for 24 to 48 hours after stopping the drug. Conclusion. In clinical practice, all three agents were superior to warfarin in stroke reduction. Xelto was non-inferior in the study data. All three drugs reduce major/intracranial bleeding risk. All three drugs have a higher non-fatal bleeding risk. All three drugs rapid onset, short half-lives. Conclusion: Pradaxa has high renal clearance. All drugs need a dose reduction for low CL. All drugs have a black box to bridge with Lovenox/heparin after stopping. Pradaxa has known higher GI side effects. Xelto used in DVT/P/hip surgery. All have high/variable cost to the patient. Doctor-patient discussion about stroke risk, bleeding risk, and all options.